Good morning and welcome to this public board meeting. I'm Martin Kirk, I'm the Vice Chair and I'll be chairing this meeting. We have apologies from Gillian Norton and from Carol McLaughlin. Just one thing I'd like to say at the beginning is that you will see that it's a reduced time meeting, clearly reflecting the operational pressures that we have at the moment and the need to give those who are coping with that the maximum time that we can. Of course, it's easy to make that decision. It's harder to actually implement it, and we will really need to keep to time. And the meeting will finish at 10:30. Hopefully, we'll have covered everything. But if not, we'll respect the agreement and we'll follow up outside the meeting on the rest of it. So, are there any declarations of interest? Aruna?
Martin, I'm doing some consultancy work for the Royal Cornwall NHS Trust. I don't think there's a conflict, but I should declare it.
Okay. And anybody else? No. Okay.
Yeah. Sorry. I was just having trouble raising my hand. Yeah, okay. My role at St George's needs to be noted.
Okay. Thank you.
Likewise, I wasn't sure whether we were still declaring that or not, but if we are, then that's me and Anne, isn't it, as well?
Okay. Anything else? All right, we'll go to the minutes of the previous trust board meeting. Any comments or changes? No? Okay, so I'll do my update. And I wanted to use this time to pay tribute to our staff and all our wider workforce for the incredible job which they've done for a very long time now, and the extraordinary dedication, professionalism and resilience that they show. I know many are very tired and very stressed, but we often hear words like that. So I wanted to try and be a bit more specific about what it was that, my own view, what it was that we were thanking them for. The first one I'd say is the sacrifices over Christmas, in particular Christmas and New Year, in having to work when I'm sure that many would have much rather been with family and friends, and that is a sacrifice that people have made. The very long hours that that people have worked throughout the organisation, and the extra shifts that many on the front line have taken on that they'd rather not be doing. Again, I'm sure they'd rather be with family and friends or having more time off, but they've done what they needed to do. And covering for sick colleagues, again, you know, we hear the numbers about the effect of Omicron, particularly in terms of staff absence and increased staff absence, but probably less so in terms of thinking about what that actually means for people on the ground and the need for them to cover jobs and cover other people's work. And also the flexibility, which has been going on really throughout the pandemic, that we still have significant numbers of people who are doing jobs that they would not normally do. And I think those are the kind of things that we need to be very thankful for. Our performance, as we'll be hearing more about, compares favourably. And I think all colleagues should be proud of what they've achieved. And I'd like to pass on the thanks of the board. So the Chief Exec's update is next, and that will be Jacqueline.
Good morning, Martin. Sorry, I couldn't get myself to hear anybody initially, so I had to go out and come in again. And I clearly do have a conflict of interest as my double-hattedness as a chief exec for both Epsom, St Helier and St George's. Just in terms of the Chief Exec's report, just a few things to pull out, if I may, Chair. One is vaccinations, and we have been very focused on vaccinations, particularly around our staff and trying to support our staff and help them around making a choice to have vaccination. And I was pleased to see both James and Arlene be asked to talk at last night's regional chief exec meeting, because we have done particularly well here at Epsom St Helier in regards to supporting staff to be vaccinated, but more on that during the board meeting. We have also made a decision last week that, given the pressures that we have, that we would delay the new executive group structure to the beginning of February to allow our sites to begin to hopefully reduce the burden of Omicron and begin to get back into their normal battle rhythm as much as we can. So the new structure will start on the 1st of February. We've also been able to showcase quite a lot of Epsom and St Helier over the last month, whether it be integrated care or how well we've done in ophthalmology or in terms of Swelliop. So that's been a real joy to see that we've been recognised nationally around the work that we are doing in terms of treating patients in our organisation. With that, I think, Chair, I'm not going to say much more, but I'm happy to take any further questions if helpful.
Thank you, Jacqueline. Any questions for Jacqueline? Okay, so we'll go on to James, who's going to do the COVID-19 and operational update.
Thank you, Chair. I think it's just a marker of how rapidly this surge and this pandemic is evolving, that this paper, albeit at high level, was drafted last week, and it already feels as though it's significantly out of date. But just a little bit of context. We're all aware through the national news and our lived experience that through December and early January, we have seen a massive surge in community prevalence of COVID. London was at the epicenter of this surge and has probably seen an earlier rise than other regions in the country. But the national data suggests that the community prevalence in London has peaked at or around New Year, but there's inevitably a slight lag phase in terms of what is the impact on changing community prevalence and the impact on acute trusts such as Epsom and St Helier, typically with a 2-week lag for the effects of changing prevalence and changing impact on admissions. Our local area is probably behaving slightly differently compared with some other parts of London. And we know that Sutton in particular has seen extremely high rates and the highest rates of community prevalence in the country. And that has possibly affected St Helier Hospital in particular in a slightly different way to other trusts in London and partly in southwest London, and I'll touch on some of the detail later. However, the operational pressures are not all about COVID, so it's important, whilst I'll give some updates in terms of COVID, we do need to put this into context with other factors. So there's the direct impact of COVID and the patients that we are treating who present to our hospitals with COVID or develop COVID in our hospital or are incidentally found to have COVID whilst they present for other issues. We are experiencing the impact of significant staff absence because of COVID, and I'll touch on that. Clearly the need to maintain rigorous infection prevention and control measures, the risk of other winter pressures such as RSV, which is a seasonal illness that affects children particularly, and flu, and underlying this, our realization that we do need to keep the show on the road and maintain our planned care, our diagnostics and our outpatients, so that we are cognizant of avoiding patients waiting too long on waiting lists for their definitive treatment. So to date, Epsom and St Helier have now discharged over 4,000 patients who were COVID positive through the course of the pandemic. We have seen rising numbers of COVID patients through the course of December, and whilst other trusts in London are now starting to see a reduction in the numbers of new patients presenting with COVID and the total numbers of beds occupied with COVID positive patients, we are still in the past week seeing a drift upwards in our COVID numbers, but hopefully our numbers will start to plateau. Unfortunately, we are beginning to see in our local population a clear trend of reducing community prevalence. So we currently have 137 of our beds occupied with patients who have been diagnosed with COVID. That is 87 patients at the St Helier site and 50 at Epsom. And this represents 21.8% of our available general beds. Unlike the other surges, thankfully, we have seen fewer patients who are needing the most intensive care. And this is probably a reflection of the changing nature of Omicron compared with previous variants such as Alpha and Delta, the new treatments that we have available in the community for the highest risk patients, and a plethora of new treatments that have been designed to specifically treat our sickest patients in hospital. And we are really pleased that as a trust, we have been very active participants in probably the largest and most dynamic multi-center trial looking at COVID worldwide, which is the recovery trial. And our clinicians and patients have contributed to some of these really important developments to ensure that we can offer the best treatments for patients. So at present, we only have 2 of our intensive care beds that are occupied with COVID patients. In the previous 2 surges, we typically saw a ratio of about 1 to 8 or 1 to 10 of our patients being treated on intensive care. But at present, we've only got 2 out of 137 patients on our intensive care. We've received a very interesting request for data about the ethnicity, the vaccination and the age profile of our patients, and Arlene will pick that up later in the board, or if there are specific questions, I'm sure Arlene will be able to help with that later. We were really challenged between Christmas and the first 2 weeks of the new year in terms of staff absence directly related to COVID, either staff being directly symptomatic or having household contacts who were symptomatic. And I think we have to acknowledge the huge contribution that so many of our staff have given to support safe services in our hospitals at a time of what is always a really challenging time between Christmas and New Year as people look to take additional annual leave. But it was really so impressive about the willingness and the flexibility of staff to give up leave, provide additional shifts, and to provide support at short notice by making themselves available on backup rotas. And we're extremely grateful for our staff that we've been able to maintain safe services throughout this period. We peaked around New Year with about 8.5% of our staff absent, and at peak, somewhere between 1/2 and 2/3 of those staff absences were directly related to COVID. Over the past week, we've seen a significant reduction of staff absence, and this is in line with other trusts in London. And on today's report, we've seen our reduction from peak COVID absence by 50%. So today we've got 148 staff who are absent through direct COVID reasons, and that represents just over 2% of staff that would have been expected to be at work today. As a result of the challenges that we've experienced with staffing, we are grateful that the corporate services have reviewed their priorities for the month of January and have been able to release some staff to support the wards. And we're getting really positive feedback about the support that's being offered on the wards, particularly with interfacing with contacting relatives of inpatients, supporting some of the visiting and providing some really good touch points. And so I think we'll have to give some thought as to how we can learn from this once this surge is over. And in addition, a number of our specialist nurses who often concentrate on some of the planned care activity are reprioritising some of their time so they can make themselves available to support the wards. Arlene and her team have been really proactive with the huge number of rapidly evolving guidelines relating to infection control, visiting, isolation for staff and household contacts, and overseeing and implementing vaccination as a condition of deployment. And I'm sure Arlene will be very happy to take some questions relating to those issues. And then finally, in terms of our ability to manage the flow through the hospitals and planned care, whilst our performance has not been what we would aspire to be, I think by regional and national standards, the team have done incredibly well. We've recently seen the publication of the November data for patients who've been waiting 52 weeks for treatment and 104 weeks for treatment, and the numbers are eye-watering. I think over 18,000 people nationally have been waiting 2 years for definitive treatment. We're pleased to report that we currently have no patients who are waiting 104 weeks for treatment, and over 300,000 patients nationally are waiting 52 weeks, and our numbers compare favourably. And Sue will be able to provide the details, but my understanding of the latest figures are that we have 160 patients who are waiting 52 weeks for treatment. Our clinicians continue to prioritise the most urgent patients for outpatients, diagnostics and definitive treatment. So I'll pause there, and as a team, we're very happy to take questions, Martin.
Thank you, James. So questions for James or indeed others? No. Okay, so we'll go on to Ruth is going to talk to us about the Ockenden review of maternity services.
Thank you very much, Chair. This is a very short update. The board will be cognizant that it previously has reviewed and approved the Trust's gap analysis and action plan against the 12 recommendations of the Ockenden review. Subsequently, this submission has been peer reviewed. This verbal update is to confirm that progress against the plan is and will continue to be monitored and discussed in detail monthly at the Patient Safety and Quality Committee, and to seek the board's approval to continue with this review process via the Patient Safety and Quality Committee. In addition, whilst updating on Ockenden, in terms of the CNST programme, which mandates 10 key safety actions for trusts to follow in order to optimise the quality and safety of maternity care. Again, although nationally reporting requirements have been suspended in December because of the pandemic, the board should note that the Trust continues to progress against the 10 key safety recommendations, and that the work is reviewed on a monthly basis at the Patient Safety and Quality Committee. Specifically, in December, the Patient Safety and Quality Committee approved some training mitigations that we had to put into place, given that face-to-face training has had to be reduced in terms of capacity, given the constraints of the pandemic. So the board is asked to note the ongoing work in relation both to Ockenden and CNST, and to support the continued review, monitoring and scrutiny via the Patient Safety and Quality Committee.
Thank you. Questions for Ruth? Okay, so we're going to go on to the other parts of the agenda, like the IPR and the committee reports that we normally cover. But given the time, they've been put for in writing for everyone to see as information. But equally happy to take any questions. So really, from a practical point of view, we could now have questions, and we do have time, questions on any of those aspects, or indeed if there's still anything from James or Ruth or Jacqueline's update that colleagues might like to ask, please do use the time to ask any questions. Peter.
Yeah, it's just an observation in a way on the finance report, and whether it's a question to Anne in that sense, which is, I understand we still have not received our budget allocation for the next financial year. And given that we're only now a matter of weeks away from that, I mean, would you agree, Anne, that this makes planning for next year's budget incredibly difficult? And we ought really to be getting, I've had it sooner, and indeed had a longer outlook and medium term plan to enable us to plan for the medium term. Thank you.
Do you want me to respond to that, Martin? So,
Yes,
you know, I suppose I'm 5 years into my NHS NED career, so I'm not surprised that we find ourselves in January without having a budget for next year. Clearly, I don't think that's a good place to be, and I don't think it helps the organisation to plan effectively. But the NHS has learnt to live with that. I think there are some changes this year which will make our budget planning more complicated. The move to system working means that there's an extra stage in the kind of budget delegation, because it will go to system, and then the system will need to decide how much goes to individual trusts, which I think makes it more complicated. Having said all that, I do think it's important that we do some planning. And I think some of us were perhaps a little disappointed that we hadn't made more progress in our November meeting, but I'm sure that we will address that when we meet this month.
thank you. Other questions? Sue.
Sorry, Martin, I can't see where my hand up button is. Not a question, but I was just going to elaborate a little bit around the performance and linking in with James's report. So James mentioned that we're in a strong position in South West London, as I think you alluded to as well, Martin. Our urgent care position is in a favourable position. We are performing at, we can see everyone within 80% of people within 4 hours of being in ED. We're managing to keep a high number of patients out of hospital with the use of our same-day emergency care department. So in December, we saw over 200 patients through that facility. And 2 years ago, these would have been patients who came into hospital. So our admission rate we're maintaining quite a low admission rate, and we're discharging fairly high numbers of patients, and our readmission rate is also low. So that is a really positive reflection on how well our new ED system is working. And you'll remember that we invested about £3 million last year in the infrastructure, and it's just feedback that it is working really well. In plan care, James mentioned 160 patients waiting over 52 weeks, but it's also a positive. I'd like to positively report that we've only got 3 patients waiting over 78 weeks. That's another metric that we look at, and 0 over 104. But we can see from only having 3 waiting over 78 weeks, we're well within the threshold for those. And I attended one of our divisional meetings yesterday, where they go through every single patient who's waiting over 40 weeks, and we know that they've got a plan. So there's quite a lot of diligent attention paid to every single patient on our waiting lists every week. And from a cancer perspective, we are also performing well in November. We unfortunately failed the cancer 62-day target for September and October, but for November we are back and reporting a performance of over 85%. And also, just in terms of the COVID report, our planned care has continued throughout this wave of COVID. It's very different from previous waves. We've paid a lot of attention to maintaining theatres and outpatients, but I'd just like to inform the board that we have plans in the background for taking down planned care to be able to respond to the need for more capacity for COVID patients should that be necessary. So all the planning has been done, but fortunately we haven't had to enact any of those plans to take theatres and outpatients down to support the wards. That doesn't mean that the planning hasn't taken place. And in ITU, we've managed to increase from 13 to 17 beds without having to move any theatre staff over. So that's through the use of redeployment and increased recruitment of overseas nurses. So overall, we've managed, I think, much better during this wave than we have done previously. So just a little bit of extra information.
Thanks, Sue, and completely agree. I think in particular the ED and the planned care performance has been exemplary. Chris.
Thank you very much. This question may have been asked already, I apologise, but my internet connection dropped off for about 5 minutes. Have we, so it's for James or Sue, have we had to open any extra beds as we often have had to do in the past over winter?
So, Chris, we have every bed available to us open at the moment, but we're in a bit of a different position this year. We have some beds that are closed due to having enabling works done to them to allow the renal services to move over into the main block next year. So all our available beds are open, but I think it's fair to say that our bed stock is reduced from 2 years ago. So we do not have as many beds as we had 2 years ago, but that is because we're currently undergoing work to allow renal to move over from the back of the hospital into the main hospital. So the answer is yes, we have had to open up additional beds, but we don't have as many as we have had previously.
And just touching on the comments that Sue was making earlier, Chris, that we do have backup plans to further increase escalation capacity for non-elective care should the need arise, but that would have a direct impact on our ability to deliver planned care. So we're keeping close to that on a daily basis. We're also working really closely with our partners across the other acute trusts in southwest London to ensure that mutual aid is provided where necessary so that we can maintain safe flow for non-elective care, but maximise the opportunities for patients to access planned care. So there are backup plans for additional escalation beds should it be necessary, but we're really trying our hardest not to enact that plan.
And Chris, this year, we've really tried hard to focus on capacity in the community to look after our patients. So working with Sutton Health and Care and Surrey Downs Health and Care, we've worked up plans to build up the schemes that they have to keep people out of hospital and to receive them earlier in their hospital pathway in terms of discharge. So discharge to assess, or the home first work that we work on, and developing the virtual ward. So rather than focus on just putting more people into the hospital, we've tried to focus on keeping people in their own homes, and our same day emergency care department has definitely helped us keep people out of hospital.
Yeah, no, I'm glad, and thank you for mentioning the health and care teams, because I think they've been very integral to the success of the whole programme. Thank you, Sue and James.
Thanks. Aruna?
Thank you, Chair. Probably a question for Arlene. I think, James, you touched a little bit about vaccine and obviously the impact of VCOD on the organisation. And, you know, Arlene, I think you suggested Arlene might give us a breakdown of where we are in terms of staff that haven't been vaccinated and what impact that could have from a staffing perspective on us.
Thanks, Aruna. Chris, is it all right? Not Chris, Martin. Is it all right? I just go straight in?
Yes, please, Aruna, and then go on. I was going to come to you next anyway, so perhaps point and then what you were going to say.
So to Aruna's point, the vaccination as a condition of deployment work for us started last year, and we have utilized vaccination track or flu track, as it's called, for our campaign for flu and for COVID, which has enabled us to get the data right. And I think that for us has been the biggest challenge, getting the data right and cleansing that. So we did all of that work early last year, and not early November time last year and into December. And just before Christmas, we were then able to send out that first letter to staff who we were from our system didn't have any records of them having a vaccine. And so that was about 700 letters that we sent by email and post. And from that, our return was quite low in terms of staff coming back to say, look, I have had a vaccine, or anything really. Just about 9% of staff responded, but we did have Christmas and New Year, so we took that into consideration as well. And this week we have sent out our second letter, which is more strongly worded and is aligned to the George's letter that has gone out to St. George's staff, being very clear that this could result in staff not being able to work after from the 1st of April. So we have, we know that we have about 500 staff, and this was yesterday, and it's changing all the time. 500 staff who we still don't have a record for. What we have done is that we've progressed the processes, and we have done the necessary work to ensure that we can share some of the data with senior managers in the organization. And then we have been able to get the names of those staff now to the senior TRI so that they can start having the supportive conversations. Still at this point, it's supportive conversations with staff, but we know that the new guidance will come out today, the updated guidance. And from what we've heard, it's not, you know, we're going to be moving beyond the, we really want to support you, but we will continue to do that. We've done quite a bit of work with our networks, our Reach network and our disability network, our women's network, around, you know, sharing the message about getting support for staff, and we've linked staff into various webinars. So as we are here today, we have about 500 staff all in who haven't had or we don't have a record of them having any vaccines. And that is, and the work we're doing now is about getting them to return and have conversations. We recognize that there will be a group of staff, and all of us will know, that will absolutely refuse to have a vaccine, and we are doing all we can to persuade them and support them. And we will be working with George's on the next steps for those staff in particular, and you know, if we've run out of redeployment options. Our hotspots, as they were, are ED and AMU, nursing in particular, that we're worried about, phlebotomy, and our catering, our catering staff, who probably don't think that they're in scope because they're not patient facing, as it were. So we will be doing work to get them to supported. And the other group of staff that we are worried about, well, I think just it's mostly ED, is maternity, but because nationally we know that maternity, there is an issue with maternity staff having vaccines. We don't have that experience, fortunately. So we have a number of midwives who haven't had a vaccine, but it's not a huge number in comparison to the total number of midwives that we have. So, but you know, midwifery have a really vibrant Reach network, you know, a subset of the Reach network, and they have some amazing work in supporting midwives to get vaccinated. So that's where we are with the vaccination, and it's an ever-changing picture. So yesterday alone, we had 50 more staff contact us to say, here is my evidence. So we are getting there.
Thank you, Arlene. Does that cover what you were going to say as well?
No, I was wanting to come in on the issue of staffing, because I know that, you know, like Sue said, we have some areas that are open, and on the IPR, we have the staffing on there. I think it's really important for me to highlight that the staffing that we have on the IPR is always an average, and that's the best that we can do, or anywhere else, an average across the month for staffing. But the areas I think that we and we are conscious of and working to ensure that we have the support for our escalation areas. And you'll see from the IPR that, you know, in a lot of areas where we have low registered nurse numbers, we have, you know, 100 or 150% of unregistered staff. And that's not to say that those unregistered staff replace the registered numbers, it just provides some additional support. So I just wanted to highlight that. And the final thing in terms of the IPR is around infection control. Of course, all of the work that is going on, as James has mentioned, around the guidance that keeps changing, and then we have to adjust and ensure that our staff are updated, isolation, lateral flow and all of that, and that is keeping the team busy swabbing as well. We, in terms of the board, in the update about aspergillus, which is on this IPR, just to say that we confirm that there have been no new cases associated with the incidents that we found late last year, or in the summer and late last year, and we will continue to update on that as we go. So that's it from me. Thank you.
Thanks, Arlene. Peter.
Thank you, Martin. And if I may just go back briefly to James's report on a couple of points. One is just to welcome the positive feedback on the redeployment, with the corporate services kind of moving in and helping on the clinical side. And my sense is, from what was said, that there may be some enduring benefits if that became something that could be built into practice going forward. So I'd be interested to hear back at a future point how that may be taken forward. But the second point is just on visiting policy, and to what extent is this entirely dictated by national guidelines? Is there any local discretion, and is there an indication of when there may be some more flexibility? Because just conscious of the fact that one visitor rule will be for many in the hospital quite difficult for those, and as long as it could be done safely, the sooner that could be flexed, presumably would be welcomed by many. Thank you.
So if I take the question on the visiting, so we are constantly reviewing the visiting guidelines. At Epsom and St Helier, we have not changed from the one visitor rule, and of course for patients who need it, they can have somebody with them plus the one visitor. For patients who are end of life care, they can have you know, more than one visitor. So we are we have been very flexible all the way throughout, and we will continue to do that. And you know, we try and work again across Southwest London, very much aligned with the other trusts, what we're doing, and we do facilitate some virtual visiting as well when that's possible for the patients. So we're very conscious that visitors are key to the recovery for patients, actually, and therefore we will maintain as much as we can the level of visiting that we can to keep patients safe.
Okay. More questions? I had one for James. There's been quite a lot of national coverage about NHS arrangements with the private sector and a new deal. Do we know yet what that means for us?
So Martin, I think there's negotiations within Southwest London about some of the private provider about what the deal will look like. I'm going to hand over to Sue, but I think it's still in a state of ongoing discussions.
Yes, James, I don't think I've got any further update on those discussions, but Martin, we are actively engaged with Ashtead at the moment, and we operate through their facility. We've got a theatre running down there, and we also are working with Surrey Downs, looking at how we can work with the private sector on outpatients as well. So we're already linked in where we can be, and there are negotiations happening with St Anthony's at the St Helier end of the patch should we need it. But in terms of the new agreement, yes, it's been worked through at the moment.
Other questions? We do have time. Okay, Chris.
Yeah, thank you. So just on that matter, and it's a reflection more than a question, but I guess a lot of the consultants and maybe even some of the nursing staff who work in Ashtead and other private hospitals are also NHS employees. Is there a risk of people getting overloaded doing both NHS and private work? I know it's not something we can necessarily control, but I wonder if there was any thoughts on that from Sue or James.
No, I don't think we're coming across that as a problem with the providers that we're working with currently, Chris. Certainly not down at Ashtead. They've got a team down there, and if we're fielding people down there, it will be part of their regular job plan rather than an increase in their activity. And where we're working with GP practices, they're servicing their own arrangements, and we're not actually supplying them with staff.
Thank you.
But Sue, if I can come in on that as well, we are seeing that we're nearly 2 years into this, and we are seeing that there's a real impact on members of staff, and people are making their own choices about providing additional work. This has not been a short-term issue that we can expect staff to be providing over and above their contracted hours for prolonged periods of time. So as Sue's indicated, we are looking at this service by service. We're really cognizant about the welfare of our staff, and we're having to make local decisions about whether we can provide the additional capacity with our own staff or whether we need to seek support from alternative providers.
Thank you.
Derek.
Yeah, since there's time, can I just make a comment really to endorse what Arlene and James and others are doing to promote vaccination? And one of the privileges of working in infectious diseases, you do get to see and analyse and data on this very early, and talk to colleagues who are actively working in vaccination research. And the data really is astonishingly positive. The efficacy in preventing serious disease and the efficacy in reducing transmission, there's data just coming out on that as well, is really important. So I just want to endorse what the team are doing to encourage vaccination, to engage with staff. And I suppose to ask the question, is there any more we can do to dispel misinformation? Because the real enemy here is misinformation, I think. And I know you're doing a lot already, but is there any more we can do to dispel misinformation?
I think there is always more that we can do, of course, to encourage staff. I think, but what we're finding is these one-to-one conversations are key, really, and so we've got down to this number, and 500 is still a lot of individuals with which we need to have that one-to-one conversation, but those are really helping, is our experience. So I think as we will continue to promote the various webinars, to promote discussions in smaller groups in the networks and all of that. But what we're finding now is the one-to-one conversations are what's making the difference.
I think I can make a tiny contribution to that from my experience of sort of behaviour change and organisation change. I think one risk in this is that the more it is seen as a senior management top-down pressure, actually for some people, not all, because there'll be lots of different reasons why, but for some people that's actually probably going to increase the resistance. So for me, the answer to Derek's question would be the more you can do at a peer level, the more effective it's going to be. More peer pressure would make a big difference, particularly as you know, we have colleagues who are very, very good at working in teams, very team-minded. Like I said at the beginning, the way that people cover it for each other when we had high sickness, etc. So I think it's along those lines, and it's about working as a team. I think that's the key to it.
Martin, perhaps I can come in on this, because I think Arlene is underselling a lot of the work that she's been doing in terms of peer support. I think one of the areas of focus has been to use our networks to identify local champions that are respected. And Arlene has been doing a huge amount of gentle persuasion for some really high profile, respected individuals who have been hesitant to receive the vaccine, who are now coming forward. And I think if peers see that these individuals are receiving the vaccine and can then champion the vaccine, I think that's really helpful, as well as identifying the right one-to-one conversations and not backing people into corners, but making sure that people are aware of the consequences of choices they're making.
I completely endorse that. I think the networks and the work that's been done through them have been very effective. The other point worth emphasising, at least in the sense that it seems to get very little coverage in the media, is that there was a statement I know put out by all the faith leaders. So if you go back, you hear it less now, but if you go back further into the pandemic, you know, some of this at least was about religious beliefs, and that's very much an individual choice. But nevertheless, it is a fact that all the religious faith leaders in the UK have said there is no religious reason to not be vaccinated. That's not too mean negative. Okay, Peter.
It was just really because we've rightly put the corporate risk register for information today, was just to flag that the vaccine as a condition of deployment is clearly a very hot topic. And you've heard all of the actions we are taking right now, but we will be reflecting that in the next iteration of the corporate risk register, which we intend to discuss at the next people committee in more detail. So just to flag that.
Yes, and thank you. And clearly we'll have more information to share with the public once we've received the guidance which comes centrally, because of course this issue is NHS wide, and although it is expected today, we haven't yet received a lot of the information we need to be able to say more. Okay, I just had one. Well, does anybody else got any other questions? I just have one more. James, you talked about other infectious diseases in winter. And I know it's just coming to what's normally the peak season, but I wondered in terms of flu specifically, it seems to me that given the sort of precautions that people are taking to avoid being infected with COVID, though the most vulnerable people, so obviously it may be prevalent in the community, but the most vulnerable people who might end up being hospitalized, perhaps I'm being too optimistic, but if there is a flu outbreak, I'm wondering if it will be so bad. But the other question more specifically is, do we know, if there is one, do we know how serious it is? Do we know anything about the variant that's expected?
I hesitate to give too precise an answer, knowing that Derek is on the board and will probably have more precise information than me. But I think you're absolutely right, Martin, that there has very definitely been a change in all of our behaviours and social interactions. Our use of PPE, our distancing, and our attention to hand hygiene, and I think the same prevention measures for all of us to reduce the risk of transmission of COVID also applies to flu. We are in what would normally be the flu season, we typically see a rise of inpatient demand for patients who are ill with flu through the late part of December and most of January. We are seeing a smattering of cases, but we are not seeing the peaks that we have seen in previous years for flu. I'll just add the word yet. We are seeing other winter respiratory illnesses presenting, but I was in a meeting yesterday where we were just seeing the regional data in terms of the occupancy of hospital beds for non-COVID reasons across London. And it is, whilst the instant is rising now week by week since the middle of December, we are at a lower occupancy compared with a typical equivalent week for the second, third week of January. But there are probably all sorts of interplays that might be affecting that.
Okay, thank you. Chris?
Yeah, just information I've had from elsewhere on that. The vaccination rates in Sutton against flu for those who are vulnerable, the elderly and with certain health conditions is the highest it has been, I think, ever, or certainly in recent years. So there's quite a lot of population protection out there against flu. So trying to be a bit upbeat about that potential worry. Thanks.
Okay, thank you. So we'll go on to the questions from the public, which we've actually got quite a few of this time. For each one, we'll do it in the normal way that the person who's going to answer the question will also read out the question. And it starts with Arlene, please.
Thank you, Martin. So the question that was submitted by the Vice Chair of Merton Health Watch and Merton Mental Health Forum was they wanted an update on COVID admission, and of those, what percentage have not been vaccinated, and could we break that down by age, ethnicity, and gender? The demographics of COVID positive patients has evolved through the pandemic and the different surges, as we will know. Despite approximately 75% of our local population having received at least 2 doses of the vaccine, approximately 56% of newly diagnosed patients have received 2 doses. There's a disproportionate number of patients treated for COVID who have received no vaccine. And the split is about 32% male and 35% female, with marked increase in those younger than 50, which is common information really. And there's a disproportionate admission rate for patients from our non-white community. Vaccination rates in our admitted patients vary significantly in ethnicity. Although the number of patients are relatively low, in our most recent analysis, over 2/3 of COVID patients, of our COVID inpatients were from a Black African or Black Caribbean ethnicity, were unvaccinated, compared with fewer than 1/4 of white inpatients. So I hope that answers the question, but I'm happy to add any additional information if needed.
Thank you, Arlene. The other question was around, has planning permission been approved for the construction of the new hospital at Sutton? Our response is that the Trust is working with the local planning authority and the Greater London Authority at pre-application stage on the level of detail and information required for the submission of a full planning application. The Trust undertook pre-planning engagement with the public in June 2021 and planning to undertake further engagement with local residents and key stakeholders in the near future. If I move on to the next question that's been provided by Maurice Groves, and the question was, I'm sorry that I've not attended virtual board meetings recently, but I have one question. What is the timescale for the new the new building, start and completion. I know that work has started in the new Royal Marsden Hospital. And our response is that our Building Your Future Hospital programme, building a brand new specialist emergency care hospital in Sutton and significantly improving Epsom and St Heliers, is backed by government and represents the biggest investment in healthcare in our region for a generation. It will ensure that our services here to care for the local people for many years to come. We have submitted an outline business case to the National New Hospitals Programme for feedback and awaiting confirmation of next steps. Once this happens, we'll be able to reaffirm our programme delivery timelines. And I'll pass you on to Peter for another question.
Thank you, Trevor. So Keith Francis has submitted 3 questions. I will cover the first 2 and then hand over to Thirza for the third. So the first question is a statement saying, stop falsely saying that the board meetings are in public as hiding behind Zoom and the fact that we can't attend them in person. They're most certainly not. A New Year resolution for the Trust Board should have been the phrase, get off your bed and walk, and meetings ought to have returned to normal. Also, as your AGM was most certainly not held in public, was that permitted under NHS guidelines? I've never seen any of my questions concerning the failure to publish the latest H1 bus timetable mentioned at any board meeting. So the answer is, the Trust is satisfied that holding board meetings and the annual public meeting virtually via Zoom is in line with national rules, regulations and guidelines in relation to conducting Trust business effectively during the ongoing COVID-19 pandemic. Our procedure for requiring written questions from the public in advance is also common practice and predates the pandemic. In relation to the H1 bus timetable, the details are available on our website, and that's at www.epsom-helier.nhs.uk/plan-your-journey, and those are regularly updated. The next question from Mr. Francis was, were we, the public, properly consulted over the ongoing takeover by St George's? So Epsom and St Helier and St George's have formed a hospital group. This is not a takeover or a merger. It is a collaboration between equal partners. Epsom and St Helier and St George's remain separate statutory organisations, and the establishment of the hospital group does not change this. The formation of the hospital group has not been subject to wider engagement because it is a change in management structures with a single executive team, enabling the 2 trusts to work closer together and build on our strong foundations. It is not a change in service model. Where greater collaboration would result in service change, this would be subject to all the usual requirements for public involvement. Working as a hospital group allows for more joined-up decision-making for the benefit of local people, a larger and more resilient workforce, reduced variation in levels of care, and more access to a wider range of services for our patients. I'll hand now over to Thirza for the final question.
Thank you, Peter. The final question was also from Keith Francis. The question is, also, without first providing a listing, stop using other letters to describe something. This was a battle I had at the former Surrey Downs CCG meetings, which I attended, and under its new guise is, I believe, another NHS organisation that too, due the use of Zoom, now prevents the public from physically attending its meetings. Although there were outstanding matters, i.e. obtaining sufficient monies from Guildford Borough Council for the Howard scheme in Effingham to provide a new doctor's surgery instead of having to rely on the overused Great Bookham doctor's surgery. I've given up looking at the agenda and minutes to see if the impossible has happened. Yes, I know that in the latest Mole Valley local plan provision for the replacement doctor's surgery, Eastwick Park and a new doctor's surgery are a possibility, but under a chicken and egg principle, will the new houses be built and occupied first? And the response from Epsom and St Helier is, due to the ongoing COVID-19 pandemic, meetings of Surrey Heartland CCG currently take place live over Microsoft Teams. Responsibility for general practitioner premises rests with Surrey Heartland CCG, who would be best placed to answer any queries about doctors' surgeries.
Okay, thank you. That completes the questions and completes the agenda for the meeting. So I'd like to thank the public who attended and for all colleagues. Thank you. That closes the meeting.